Good morning, Dr. Rosensweet.
Good morning, Carolyn Shapiro.
It is so nice to see you as always.
You
I'm
as
always
well.
repeating myself, and thank you. Welcome to the women who are going to be coming up. Thank you always for your kind and dear time because it is way, way, way appreciated by me and all of us. So, my own question, quick answer. I know it will be, but I need to know. I had told you that I fell on my knee, and I fell hard coming off the ramp of the airplane thing. And I'm wondering, 'cause I was certain I had broken it. I mean, 100%. As it turns out, I didn't. And I'm wondering if it's possible, maybe, in your opinion, if due to the fact that I've been taking hormones for the last 3 years, if maybe that could have prevented said break, osteoporosis.
It's a great topic.
It's a hypothetical, but I know.
It's a great topic, and I'm delighted to go into it.
Thank you.
I think it's a wonderful sign that you didn't fracture the patella.
Yeah, that would not have been fun.
I'm not an orthopedic surgeon, nor have I any expertise in this area, so I don't know how prone the patella is to osteoporosis or not, or whether it's an exclusion. That'd be pretty far out if it was.
True.
The thing that I think is so universal is it is so common for women to lose bone density.
Yes.
And God, I don't know if there are very many exceptions that a woman goes into menopause that she doesn't lose bone. I think some do better than others. But osteopenia and osteoporosis is an epidemic in the United States. I don't know about the rest of the world. And the principal driver of bone loss is loss of estrogen that occurs naturally, so to speak, when the ovaries stop producing estrogen.
Right.
And so of the many, many, many reasons I am such a strong advocate for all women, almost all women, to get excellent hormone replenishment. That's one of them, osteoporosis. And of course, my own mom fractured her hip. She had osteoporosis. My mother-in-law fractured her humerus. That's her upper arm, or her clavicle or pelvis when she fell. Because when you also don't have adequate testosterone, what a woman will notice is she'll be getting weaker in her lower extremities, and she'll see flab under her triceps area. She'll be losing muscle. You need androgens to maintain your muscle. And it's the principal cause of women and men, loss of testosterone, to develop sarcopenia, loss of muscle, and thus need canes, walkers, wheelchairs. Ooh, that's a tender moment. The transition from walker to wheelchair, that's often the transition to assisted living facility out of the home.
Right.
So it's a big deal. So replenishing testosterone, replenishing estrogen, progesterone plays a role in a zillion things, including bone health, DHEA, thyroid. Oh man, we've got these wonderful bioidentical versions of all these hormones. Well, I have such a strong opinion about this. Replenish these hormones.
Yes, I was reading your book actually, and I happened upon those particular pages in regards to your mother and mother-in-law and bone loss, and it's pretty fascinating. So again, happy, healthy hormones, downloadable, free. Get it, read it. It's good. I really just kind of wanted to know. I don't want to harp on me because
it's you, and it's universal. That's one of the reasons I'm venturing into it, because there are a lot of reasons to replenish hormones, and this is one of them.
Yeah.
And fracture of the hip used to be in the end game. Well, with surgery, how far surgery and hip replacement is advanced is not necessarily the end game. But then there's information out there that even if you get that hip replaced, as my mother did, you pass away within a year. So nothing's universal there. But preventing bone loss or replenishing bone, restoring bone, it's just a miracle. And if
It
you want to restore
can.
bone, you do the big stuff. Read that chapter. There's a lot of moving parts there. And there's a lot of moving parts to bone replenishing. And
Yeah.
hormones are like key. And boy, we go really aggressive with that progesterone because progesterone will help lay down new bone. We'll take a woman right up to her absolute limit, back her down a little bit. And then estrogen is crucial. Testosterone is crucial. DHEA is crucial. Thyroid's so crucial. So and congratulations that you fell and you did not fracture your patella.
Oy vey. I mean, you don't know how fast you're going until you go down. I was like, dang, holy mackerel is what I said. And I thought, I thought of Dr. R. And we're saying good morning to Kim and good morning to Melody. Welcome, you guys. Thank you for answering that. I have two aunts who also fractured their hips. They didn't take hormones and they're not gonna. I don't know, whatever. I'm a huge advocate for them. That is for sure. So I appreciate that answer, and I'm very appreciative that I did not break my knee. That would not have been cool, considering I walk up and down steps a lot when I'm working. Okay, so on to question number two. It has been stated, questioner says, she was listening to a very big advocate of the test that you and I talk of, that 5-point urine test
Yeah.
do on paper. Okay, that one. And it was said that if one is on birth control pills for more than 5 to 10 years, or has been, this is going to bind up your sex hormone binding globulin. It'll rise and bind up your testosterone as well. And it was stated that this is going to lead to low libido and that is permanent. And she said if one sex hormone binding globulin, you know, is now bound up, even supplementing with testosterone will never solve the problem of low libido. So, many of us have used birth control pills, and I, questioner, am wondering if Dr. R typically sees high SHBG with patients who have used oral contraceptives, and regarding the above, does he feel that a high sex hormone binding globulin and low libido is something that is a permanent thing for us? No, right.
Long question. Good morning, dear Kim. Dear Kim.
Aw.
Yeah. It's a good question because so many young women, of course, were and are being treated with birth control pills. So let me explain the basic mechanism there.
Thank you.
The ovarian hormones, whether they're coming out of your ovary or whether they're present in the birth control pill, the birth control pill contains estradiol in a certain form. It also contains a progestin. That's not progesterone, but it's an artificial funny molecule alteration of progesterone. That's a whole other topic. The steroid hormones coming out of the ovary and other glands, they're fat soluble only. That means it's like your salad dressing. You better shake. If you got oil and vinegar, you better shake it because the oil is sitting right there on top. It doesn't mix and it doesn't dissolve into the water soluble portion, the vinegar portion.
Right.
And so your body is so crazy, wonderful, amazing design. When those ovarian hormones come out of the ovary and go into the bloodstream, they can't just float around as little oil globules.
No.
But the design is they immediately get bound up by serum proteins. Many of you have heard of gamma globulin. It's a serum protein. It's related to the immune system. Well, there are other globulins and albumins and things that these steroid hormones can bind to. And that's how they're transported. So they're picked up at the ovary by these serum proteins, and they're distributed to your whole body because they're active in almost every cell in your body. And when they arrive at the cell, they're let go from these proteins that they're bound to. One of the proteins that they're bound to is called sex hormone binding globulin because it binds the sex hormones. Duh. And it binds them at various degrees of strength. and it binds estrogen just beautifully. Estrogen can also bind to globulins and to albumin even, so it's not the only thing. But one of its principal things that it loves to bind to and be transported around the blood in is the sex hormone binding globulin. So when a young woman who's at the absolute peak of her lifetime ovary hormone output is given additional hormones in the form of birth control pills, she's at her peak output of estrogens, and she's giving additional estrogens. Her body reads, that's not correct. What do we do about that? Well, we don't want excessive estrogens floating around. So let's increase the production of sex hormone binding globulin to bind up the additional extra estrogen. It's a
So it's
very
like a
natural
protective.
process. It's a very
Yeah.
natural process. It's one of those built-in exquisite protection mechanisms.
Well, I know that you've said that there's a particular medication that, I mean, that kind of gets off, but the
I'll get
question,
there. I'll get there.
yeah. Okay.
So it's very common for young women who are put on the birth control pills to get an elevation in their sex hormone binding globulin. Well, other hormones bind to sex hormone globulin, other steroid hormones, other ovarian hormones. For example, a woman's testosterone. Remember, testosterone is not it's a human hormone. It's not a male hormone. It's a male and female hormone. It's critical for women their whole lives. Any menopause replenishment program absolutely requires testosterone as much as does anything. Carrots, food, what you're eating, and testosterone supplementation. You want it all, along with your estrogen and progesterone and DHEA.
Like the appetizer part at dinner?
Well, let's
Little
call
plate
it
of
a main
testosterone?
course. It's so important.
Okay.
So
Okay.
when the sex hormone binding globulin elevates, it binds up other stuff too. In fact, testosterone has a greater binding affinity to sex hormone binding globulin than estrogen does. There's a hierarchy of binding, and testosterone's at the top, or a metabolite of testosterone is. And so young women who take birth control pills often get an elevation of sex hormone binding globulin, and what happens? They bind up some of their testosterone, and a certain percentage, not all young women, lose some libido when that happens. Now, how this question was phrased sounded like an old-fashioned, old world way where the medical curse has been given, because the words it always happens, you can't refix it. That's what I heard.
Yeah.
And I want to say
Permanent.
that that's not how life works. That's not how the body works. Healing is possible. Healing is wonderful. Healing is amazing. I can assure every one of you that you can heal all kinds of things, including the worst diagnoses you could ever imagine. People on this planet have recovered from the worst of the worst of the worst diagnoses. And sex hormone binding globulin elevation is not an illness.
Right.
It's part of a natural mechanism. So you'd think when a woman went off the birth control pill, thus she was no longer getting the extra estrogen, the sex hormone binding globulin would return to normal. Yeah, it does in many but not all cases. So some women get an elevation of that sex hormone binding globulin and it stays elevated. And there's one of the things that it's in the menopause method is this mandatory blood test right out of the gate to see whether you have an elevated sex hormone binding globulin. We're going to follow that over the years. And lo and behold, there's a certain number of women who come into the menopause, they've got an elevated sex hormone binding globulin. And then we search for the cause. Oops. The only cause we've turned up in so many women is that they once were on the birth control pill. And it doesn't have to be for years and years and years. It could be a couple of months. I've seen so many elevated sex hormone binding globulins that I've learned that it doesn't take much to elevate it and keep it elevated. Now, I'm not interviewing all the women who never had that elevation. So, this isn't exactly a scientific study I'm reporting, but I can tell you for sure, You can get an elevated sex hormone binding globulin. It's not a disease. It's not an illness. And we can work with it. And I wish there were some nutritional supplements or some dietary changes or lifestyle changes that would drop this. And I've experimented with quite a few, and no, I have not found that magic remedy. But there is a pharmaceutical medication which is very, very reliable in dropping it. Now, before I go there, what did I want to say? I had to drop the thought. So I'll go to anyone who has an elevated sex hormone, I remember, anyone who enters menopause and we see on their initial blood test that they have an elevated sex hormone binding globulin, we don't necessarily try and do anything about it. We'll go ahead and do the hormone treatment program just like we always do. In a lot of women, that elevated sex hormone binding globulin is not a problem. So I barely mention it to a woman, and I certainly don't give her the curse like your questioner got the curse. She got the curse. The curse was, you're in trouble, and
you're going to stay there.
Bad news, and it's forever.
Yeah.
So, yeah. So
yeah, I think that
we'll proceed into a hormone treatment program, and we won't try and do anything about it. And very many women will just do beautifully with the hormone treatment program, and the sex hormone binding globulin that is elevated will never be a factor to be concerned about. There are some women that it does interfere, and we can tell pretty early on if she's not having the usual response to the hormonal program. Then we start looking at that sex hormone binding globulin. And there is a pharmaceutical medication. It's called danazol, and it's used for endometriosis. It's been around for a long time. The dosages we're able to use to lower the sex hormone binding globulin are minuscule compared to what they were for treating women with endometriosis, for example. So there's a lot of safety there, but it's not 100% without possible consequences. So I'm careful when I turn to danazol that I monitor the patient, because rarely, but it has occurred when I've treated women for 25 years, treated a lot of women with danazol. Occasionally there is a discrepancy that occurs in the white blood cell count.
Yeah.
So we monitor it. That's part of what we're doing annually. And if we pick it up, we have to reduce that danazol dose or eliminate the danazol and go to other ways to deal with this, because there's always a way. There's always a way, period. Anything on earth, there's always a way. So we find that way. And so that's some information about sex hormone binding globulin. It is not a disease, and it is not it's not even something that's not overcomable. And I tell you, I've handled some of the most complex sex hormone binding globulin cases that imaginable, and we always figure out a way. So don't worry about it.
It's very uplifting, and I like that you say that we can heal from anything, and most things, and many people can, and you're very right. Seen it, been there, done that, and it's a very invigorating, kind, positive statement that you made. Really, it's a big deal. Thank you for answering that, Dr. R. So next question comes in stating, and I got a second one actually early this morning that relates to this. I know that Dr. R advocates for stopping biased and progesterone 2 to 3 days per month, give or take. But do we also do this with testosterone and DHEA? Thank you. And if so, why?
I'd like to explain why I advocate that. And it's not in all cases. But these hormones are all fat soluble. So the ovarian hormones that you take, that includes estrogens, progesterone, testosterone, and DHEA, are fat soluble. That means part of the hormones you're rubbing into your skin or taking in another manner are going to your whole body and doing the thing that they do. And part of those hormones are absorbing into the adipose tissue, the fat tissue in your body.
Right.
And it's just like vitamins in a way. There's water-soluble vitamins and fat-soluble vitamins. And water-soluble vitamins like B vitamins, you could take a massive overdose and you just pee it out. because it's not going to accumulate in the fat tissue. But these fat-soluble vitamins like vitamin A and vitamin D, for example, you can take too much of those. They will build up in the body. People who take too much vitamin A, man, they'll turn yellow because it's accumulating in their fatty tissues in their body. You can get overdosed on these fat-soluble vitamins. Well, theoretically, you could get overdosed on steroid hormones, which are fat-soluble as well. Now, usually that doesn't happen. It certainly doesn't happen in the menopause method because, for one thing, these hormones speak loudly, and excessive amounts of them most often lead to symptoms of excess, which
And
you
you
can read
feel
about
them, yes.
in our book. You feel those things.
Yeah.
And you don't like them.
Mm.
But sometimes they're not that obvious. Certainly not 100% of the time. The other way that we work within the menopause method is we do a 24-hour urine hormone test. We test only when a woman has arrived at optimal dosages determined by symptom alleviation. So it's usually the 3 to 5 month mark that we test. It's not worth it to test before that, except in rare exceptions. So we have a couple safeguards there that we're not going to be pushing excessive levels of hormones. But sometimes women require a more robust level of hormones. That's especially true when there's cognitive challenges. So you never say never about hormone levels. Sometimes we push them into really robust, and that's a subject unto itself. Now, if a woman is taking 20 more molecules of estrogen than her body actually needs each month, as an example, theoretically, those extra molecules are not going to be peed out. They're going to be accumulating in the fat tissue of her body. Well, how many days does it take before she's got an excessive level of estrogens in her body? Well, it's going to be pretty slow, 20 molecules. My God, I don't even know. I can't even know how much that is. It's a jillionth of a drop or something. But, get the picture. If you're taking a little bit too much, it's going to accumulate in the fat tissues. So one way that we address that, because it's like hormones, there's 1,000 moving parts, or hundreds of moving parts, and we address all the moving parts. So as a natural mechanism to prevent hormone accumulation, if a woman stops taking her hormones once a month, we believe that that's going to be a hedge against overaccumulation of these hormones in adipose tissue. And here's how we do the process. We say to a woman, okay, on the first of the month, because that's usually the easiest thing to remember. Some women correlate it with the moon. It doesn't matter what you correlate it with. On the first of your month, don't take any of your hormones, none of your steroid hormones, none. And that addresses something that's in the woman's questioning. And see what happens. And let's say the first day she feels fine, the second day she feels fine, the third day she has a hot flash. What happened? She dropped below adequate levels of hormones. So what we tell her is, from this point on, stop for 2 days every month. We don't need to take you into developing a symptom of insufficiency like hot flashes. We don't need you to do that once a month. That's not helpful. It's a little disruptive. So if you got a hot flash on day 3, we're going to have you stop for 2 days every month, and that's it. And that's one of the ways we'll prevent accumulation of hormones in your adipose tissue. Now, let's look at a couple exceptions here. Let's say a woman stops in the first of the month, and by that afternoon, she has a hot flash. This woman is running very lean. So this would be a woman we'd say, don't ever stop. You're satisfied symptomatically, you test well on 24-hour urine hormone testing, don't ever stop. You're not accumulating, you're running on the lean end. All it did is take 12 hours and you're already into a symptom.
Right.
You are running lean. What's the all-time record of stoppage? In my practice, over 25 years, it's 5 weeks. A woman got breast tenderness, and it took 5 weeks before that breast tenderness disappeared. Now, she was very thin, and the main adipose tissue she had was in her breast. And when it accumulates in the breast, that's a whole other story.
Yeah.
But when a woman is running robust levels of estrogen, as shown in the test results, for those of you who love numbers, if you're excreting over 14 micrograms of total potent estrogens in your urine over in a 24-hour urine hormone test, if you're running above that, we're definitely going to have you omit. And we'll see how many days it takes for you to develop symptoms, and then we'll go 1 or 2 days less than what it takes. So that's why we stop once a month. We don't stop in everybody. We always run the experiment. We stop. How long does it take? And so it's once again one of those things that are individualized woman to woman. There's some women out there that we don't have them stop at all. They're running lean. We don't want to throw them into symptoms, that's for sure. That's not helpful. It's stressful, actually.
Yeah.
And we want them to keep their levels up decently. So if they're running on the way low end, which on 24-hour urine hormone testing, that's 8 micrograms of total potent estrogens per 24 hours. We don't want them to stop. So if we look at a 24-hour urine hormone test and I see that she's running on the low end, I'm not going to advise that she stops. So every woman in the menopause method, we say, don't try this stoppage thing, even though I mentioned it in the book, until we're looking at that 24-hour urine hormone test, which is going to be at the 3 to 5 month mark. That's how we stop. That's why we stop. All these are steroid hormones, testosterone, DHEA. They all can accumulate. So between the combination of symptoms or no symptoms, 24-hour urine hormone testing, and the result of this experiment, if it's right to do, we stop once a month in most, but not all cases.
Got it. A very quickly questioner came up stating that she did stop for a week and she just got all sorts of crazy symptoms: frozen shoulder, she was nauseated, she really felt.
Yeah, we don't want every woman to stop. And
Right.
we definitely don't want to stop if they develop symptoms really quickly.
Right. Got it.
So
Got
it's
it.
really important.
Got it. Well, thank you very, very much for that. The next question is, since I started a low dose estradiol patch, some old symptoms are coming back. About a year before menopause, I had a lot of tingling in my legs. Post-meno, that stopped, but now, being on this low dose of estrogen again, I had stopped the estrogen, then found that I was postmenopausal, went back on the estradiol, and this tingling came back in my legs, and I can't understand this, and I'm wondering if you've ever heard of this.
Well, I've definitely heard of tingling in the legs. And here's what I think most. And this is what we train, and this is what we teach our doctors and nurse practitioners, that when a woman is of perimenopausal or menopausal age demographic, she's liable to show up at your office with a long list of symptoms. Rather than do an extensive medical workup for all these symptoms and all the possible diagnoses, treat her menopause first and see what remains.
Right.
And it's amazing how many things clear up and how many obscure symptoms clear up. If they don't clear up and you tested her and she's on a really good perimenopausal or menopausal program, then you can do some investigating. And I've seen all kinds of wildness clear up. The other thing that came to me when I was listening to this questioner is there's so many moving parts to male and female hormone balance, much more than you would expect. And one of the things that happens, if you don't get that treatment right, you're going to have all kinds of bizarre stuff. And it's part of a natural feedback mechanism. You're getting treated and your body's saying, no, weird. It's a weird thing. Weird stuff is still happening.
Yeah.
What that tells me is it's just not correct. The treatment program is not correct. So honor and respect that. And here's your job. It's the same job. It's always the same job. Is your job as a perimenopausal or menopausal woman is to seek out an absolute a healthcare provider that can write a prescription. That means it's going to be a doctor or a nurse practitioner, and in some instances a PA, that has had extra training and education and experience in treating women in menopause. and find someone that you're really compatible with, that you like. There's a lot of good people out there. I know some of you have had some unbeneficial experiences with some in the healthcare profession, but there's thousands and thousands of wonderful, caring people who devoted their life to this not easy work. In case anyone wondered how easy it is to be at the prescriber end of things, the provider end of things. Find someone you really like and get it right.
Got it.
And one of the things I read between the lines, and I don't know if I'm correct or not, is this woman just did not have good treatment, because you can't be messing around cutting up patches and stuff.
Right.
It just doesn't, there's not enough there. For one thing, it's just plain old estradiol. For another reason, the every 3 days things never made sense to me. For another thing is, what about testosterone? What about progesterone? Oh my God. So there's so many moving parts, and each woman is an individual. And not only do you have replenished all the hormones, that's crucial because you lost them all. There's no exceptions. You lost them all. Small, medium, or large, you lost them all. So
Right.
replenishing them, but getting your individual balance correct, it's a piece of work, and it can be a piece of work during the first 3 months, 5 months, or even a year. But once you get it, it's great. You're going to get it for a long, 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 long time. Maybe for the whole rest of your life. We check in with women every year, and at most it requires a tweak. So be patient, get it right. Boy, it's the most significant thing I believe that you can do biochemically for your health, is replenish those hormones and get it right. That's what's really crucial. I did not hear in that questionnaire that anything was anywhere near getting it right.
Yeah. And balance.
So the job becomes, find someone that you trust who cares about this and is doing good work. There is a question that popped up, Carolyn, that I would like to address.
Please.
From Sarah.
Yeah, Sarah.
I'm just going to deal part with this question because there's many questions in here. What hormones is needed to deal with bladder leaks when sneezing or coughing? This is very, very common and very, very crucial. And there's a couple of them. For one thing, it's common but not universal that the muscle that holds up the bladder and the uterus, it's a big one. It's the whole pelvic floor. The floor of your pelvis is a muscle called the levator ani. You can contact part of that that muscle. Let's all do it together. On the count of 3, let's all squeeze our anus as tight as we can. 1, 2, 3, squeeze. That's the levator ani. And it's a very crucial muscle. And being a muscle, it undergoes the same loss of muscle. Look at elderly people, if you can, as people in Florida can. When they see them walking, they got very thin thighs and they've lost a lot of muscle. Well, you also lose the levator ani. So one of the most important things for a woman who's losing her urine when coughing or sneezing is the restoration of health to that levator ani. And you are going to need optimal, great levels of testosterone to do that. They'll serve your whole life. You can also do some exercise, that very exercise that I just asked us to do. Let's do it again. Squeeze. I'm squeezing. Let go.
No one will ever know.
Do that several times a day. But you need the testosterone and the DHEA. You absolutely need the testosterone. You got to get it right, too. You can't just get a homeopathic dose of testosterone. You want the right amount, and that can be confirmed in 24-hour urine hormone testing. The other one that makes a major difference there is the bladder has a tube through which the urine passes and goes out of the body. And that's called the urethra. And that, as almost everyone knows, is in a woman, it comes out that urethra opening is in the end of your vagina. And that urethral opening can be very sensitive to the health of the vagina. So a young woman has an extremely healthy vagina. And one of the main reasons she does is there's a rich, robust amount of estrogen and testosterone and DHEA and progesterone. And the health, as far as hormones go, of the vagina is very, very, very dependent on the level of estrogen. Well, when you go into the perimenopause, you're already quite low in estrogen. And when you go into the menopause, you have very, very little estrogen, certainly not enough to support the health of the vagina. The vagina
Right.
tissue atrophies, and it gets thin and
Mm.
dry, and a woman has pain on intercourse very often.
And in just walking, I mean, it's pretty brutal.
So one of the 20 main reasons, those are the major reasons to treat a woman in menopause with estrogens and all the rest of the hormones, is to prevent that vaginal atrophy, or if there is vaginal atrophy, to restore the health of the vagina. And that can be done with proper treatment. Sometimes if the vagina's undergone major changes, it can take 3 to 12 months prior to the restoration of decent health there, but the restoration will occur. So, as far as incontinence, cough incontinence, sneezing incontinence, you got to restore that levator ani, and you got to make sure the vagina is healthy. You're going to need adequate doses of estrogen, adequate dosages. Just because you're on estrogen, I can't tell you how many women have come to me, and when I see the dosages of estrogen they're on, they're not sufficient to protect the vagina. We know what that number is. In fact, when you're doing 24-hour urine hormone testing, you need at least 8 micrograms of the sum of estrone and estradiol coming out in that urine to have vaginal health. And if you got less, you're not going to have vaginal health. And I see women who get symptom alleviation, hot flash alleviation, and they feel good and they feel, wow, this is fantastic. And they're on estrogen, and they come in and test, and they're on half the amount of estrogen to protect the vagina and the bones. If you're not protecting the vagina, you are not protecting the bones either. So get that one right. And you can have high hopes that over time you can eliminate that cough incontinence, a very important thing to eliminate. And don't forget to do those squeezing exercises. Women have done all kinds of things. One woman puts a sign over her toilet paper, squeeze. Other women, every time she comes to a stop sign, she squeezes. I've heard all kinds of ways to remember to squeeze. Do a lot of
Maybe that could be
squeezing.
a new book.
Squeeze.
Right, called Squeeze. You know, yeah, it's a good question for sure. And I'm going to throw this in. Do you think that if someone has had a hysterectomy, that would affect any of that with the levator ani?
Well, hysterectomy is technically just the removal of the uterus,
I'm talking about the whole thing, like
and that can be
everything.
done well done, or that can be problematically done, where the support of the uterus is not as good as it used to be when it was in there. So you can get prolapse of what remains of the uterus, if it is the cervix. So that's a good question. It varies individual woman to individual woman as to whether there's going to be some droppage of what's left, and that includes the top of the vagina. But the
Right.
remedy's always the same. Improve that levator ani with adequate testosterone levels, and do the squeeze for 6 months to a year or forever.
Mhm.
Got to repair that levator ani. Hysterectomy sometimes gets confused with total hysterectomy. Total hysterectomy is often the removal of the ovaries. That's a whole other deal. When those ovaries are removed in a woman who is still menstruating, you be sure. Well, every woman needs to be on ovarian hormones.
Yeah.
But
Yeah.
every man needs to be on testosterone.
Yes, sir.
Needs to be, not. That'd be a nice thing if you're on testosterone, men.
No,
No,
needs to be.
needs to be, or you're going to wind up with things that you don't like.
Right.
Many things that you don't like. This is not just an issue for women.
Right.
So don't wind up with those things. Get early
No,
treatment. Get evaluated and get treatment.
don't want those things. And you bring those points home really, really well. I've been doing with you for a while, and
Yeah.
I am so grateful. Um, We have some other questions here, but let me get to this last one. I've been having this really did I ask? I've been having this really strange ankle pain, she says. And I know that women have complained of this really strange hip pain, but mine is in my ankles since taking hormones. And she goes on to say, as I said, I know you've heard of that strange hip pain, but have you ever heard of ankle pain? It's the weirdest thing. I'm taking hormones, I'm getting ankle pain, and any thoughts will be appreciated. Thank you. I'm not eating dairy or grains, but something really weird is going on. So, any thoughts?
Well, I'll go back to what I said earlier. A woman in the menopause or perimenopause, they can come up with a long list of symptoms, including significant pains. And boy, there's a lot of different causes for pains. Ooh, ankle, I haven't heard of it, but it doesn't mean it doesn't exist. There's always exceptions. My recommendation is get that menopause treated properly, expertly, not partially, expertly, and see if it remains. It could be the joint that happens to be vulnerable for other reasons, and without the hormones, it just pushed you over the edge. I don't know. I would never guarantee that, but I'd always recommend getting the hormones corrected just for how crucial it is that they are corrected, and then see if it remains. And yes, I've heard stories. I mean, I remember sitting with a real estate agent, a high-end real estate agent, interviewing her for her first menopausal consultation, and I see that she's on OxyContin. She was on OxyContin because of joint pain. I was sitting there debating with myself, do I really want to take on an OxyContin addict? This is not my expertise. Do I really want it? But she seemed very intelligent, and she didn't seem really narcotized. So I said yes. I said yes, and then about 5 weeks later, I'm in the parking lot of my favorite health food store in Naples, Florida, that Kim knows ever so well.
Aw.
And I wanted to bring up the mantra of the health food store owner, bless his heart, rest in peace. Don't worry about a thing. Sorry for the diversion.
It's fine.
I was in the parking lot about to walk into the health food store, and this patient comes running up to me and she says, "You won't believe it. All my pain is gone." And I stopped the OxyContin. This woman stopped the OxyContin cold. She didn't
not easily doable.
Detox program. She just stopped it cold because she needed it to control that level of pain. So I've had my dramatic lessons around pain. So I'm not saying that your ankle pain is related to hormones, but it's certainly worth a try. And if you get your hormones replenished, that's going to do you good, period. But sometimes there's other issues, so they have to be looked into. And there's functional medicine folks know how to take you down the path. Orthopedic surgeons sometimes really know what to do to get the basic diagnosis down. So I wouldn't want to discourage you from doing that. But at the same time, when a woman of perimenopausal age comes in with a lot of different symptoms, I say treat the menopause first, see what's left over.
I remember, when I first met you, we did discuss that crazy hip pain that many of us got. There was no rhyme, no reason, just had this hip pain. And, one can really never know, without maybe seeing someone or whatever. But in many women's cases, when they went on hormones, that hip pain disappeared. Gone. Maybe that'll happen with her ankles. Let's hope. So, a question came up from, I believe it's Janelle. I'm sorry if I'm mispronouncing your name. What is considered to be too high of estradiol levels?
Well, on 24-hour urine hormone tests, we've carefully defined what we consider to be the optimal range.
Optimal.
And at the too high level, at a certain level, estrogen replenishing will not do what happens to a young woman once a month. A young woman puts out a robust amount of estrogen, and it does many, many things. And one of the things it does every single menstrual cycle, it's just astounding, prepares the breast for potential breastfeeding. And it's the estrogen that's the main player there. And the estrogen stimulates the formation of new breast glandular cells through cellular division, through cellular mitosis. That's how it happens. I don't know if I'm frozen or not.
You're not to me.
And that happens once a month. And that's why a woman's breasts get fuller throughout her menstrual cycle. And then if she does not get pregnant, her breasts get less full. And the additional breast glandular cells disappear by a process called, funnily enough, apoptosis.
Love that word.
Me too. Very creative namer of that one.
Yes.
And that happens every single month. Well, we have a core belief, and really I've been supported by an obstetrician gynecologist who's written about this, written an editorial about this. He was from Harvard. He wrote an editorial about the belief that he didn't think it was beneficial to put a 50-year-old woman through monthly cellular mitosis. And he thought that these aggressive, super robust levels of estrogen that are being given, he was aware of that, dosages so robust that it had a woman continue her menstrual period on into menopause or restore a menstrual period that had disappeared. It takes humongous levels of estrogen to do that. It doesn't take youthful levels. Youthful levels will not do that. It takes between 3 and 8 times the upper limit of normal in a 20 to 29-year-old estrogen levels on 24-hour urine to actually sustain or restore that menstrual cycle. So Dr. Altman says this is not good. We don't think it's good to get breast glandular cell proliferation or put a woman at risk for breast glandular proliferation when her 50-year-old immune system is not the same as her 20-year-old immune system.
Right.
He's not saying you're going to get a problem. He's not saying you're going to get cancer. He is saying that, let's use all the knowledge we have and use common sense and not do it to a menopausal woman. So if young women vary as to how much estrogen they need to have a normal menstrual cycle and get pregnant, etc. Some women need this amount. Other women need this amount. There's an individual variation. Well, we've determined that menopausal women do really well with this amount. Look at that. It's less than the least amount that it takes for a young woman to sustain menstrual cycles. That's what we recommend. Now, we recommend that a woman does not go into excessive levels. And we define that very carefully. The upper limit of normal is 14 micrograms of the sum of estrone and estradiol, the potent estrogens, on a 24-hour urine hormone test. We don't like to see a woman go above that. In medicine, you never say never. There's always exceptions. So I'm going to repeat the story that was very impactful to me. I'm sitting... I'm about to present to the National Academy of Science on their select committee for bioidentical hormones. What a story that was.
You can all see that.
I'm about to testify in front of them, and I've done some research on the other physicians that are to be on the panel that I'm on.
Right.
And I learned that one of these physicians is on the super high dose protocol, enough to get her periods to sustain.
Right.
And she's about to sit down next to me just as coffee break is over. Dear Wanda, shout out to you, Wanda. And as she's sitting down and she introduces herself and I introduce myself to her, I look at her and I say, "Are you going to tell them about the dosages of estrogens you're on?" And she winks at me because she knew it was a thorn in their side. And she said no. And so she and I and her son went out to lunch together. And here's the story she told me. My mother had dementia. My mother's sister, thus my aunt, had dementia. And here I am, I'm 55 years old. I'm sitting in my medical office and I can't remember things. I'm starting to get cognitive challenge of the highest order. It got so intense that I'm starting to think I'm not going to be able to practice medicine anymore.
Oh my God.
But she knew about the relationship of estrogen to memory in some women and cognitive function in some women. So she started taking estrogen and she cleared up a little bit. She started taking some more and she cleared up even more. She started taking some more and she cleared up even more and some more and she cleared up even more. And she got clear back to her own self. And here I am sitting and having lunch with her. I'm telling you, she's as clear as a bell at the age of 65, certainly as clear as I was. And it turned out that the dosages she needed to maintain that mental clarity also brought her period back. So I didn't say boo, and I didn't say boo about possible consequences. I didn't talk about mitosis. I didn't talk about elevating sex hormone binding globulin. I had tears in my eyes to see an actual living human being that had restoration of cognitive function and continue practicing medicine. That's very dear to my heart, practicing medicine. This is
Yeah.
my tribe. This is a
Of
very
course.
big deal to me. And
Yeah.
so I was very moved. So you never say never in medicine. And all you do is you monitor the breast. That's all. It's not like, so there are these exceptions. We defined the lower limit of normal for the 24-hour urine by going into the medical literature and seeing what the medical studies showed about how much you need to protect the vagina and the bones. That's the lower limit of normal when I mentioned 8 micrograms per 24 hours. Notice that I didn't say how much to protect the brain, because the medical literature is very clear about that. They say sometimes the levels of estrogen you need to protect the brain is much higher. So I don't want to overwhelm y'all with this. I just want to say, find someone who's specialized in this. They're going to know all this stuff. You find someone who's doing the menopause method. They've been trained in all this stuff. There's a lot of moving parts to get this right. And my God, if there's anything worth getting right about our health for 10, 20, 30, 40 years, it's getting menopause replenishment correct. So there's the general stuff, and then there's the exceptions. And how much estrogen you need can be an exception. And if you need robust amounts of estrogen, you just monitor the breasts carefully, for God's sake. That's all it takes. Because estrogen doesn't cause breast cancer. Oh, should I say that again? Estrogen doesn't cause breast cancer. For those of you who want to become experts or get expert opinion in this, read the book Estrogen Matters by a friend of Carolyn Shapiro and Carolyn Shapiro's dad, Avram Blooming, MD. Estrogen Matters.
Smart.
So there's the Bible about risk and that hormones don't cause breast cancer. So
yes, he dug
that's what I
deep.
have to say about that.
Well, okay. I can't even believe it. We have a few minutes left, and I want to ask you this question. This is a very ad lib question, but you've explained it to me, and I'm wondering if maybe we can get by with this. We discuss milligrams, we discuss micrograms, and we discuss something called milligrams equivalent. And you've explained this to me, and oftentimes I'll be reading, on some of the forums, this, that, the other, and women are saying, I'm taking 6 milligrams of, or, 4 milligrams of, and I'm wondering if they may be mistaken, and it's not really milligrams, but it might be that milligram equivalent thing that you talk.
Well, they will not be referring to milligrams of estradiol equivalent. And I would like to explain it. I wish they would. And here's where this becomes relevant. The earliest non-horse urine derived estrogen that has been prescribed is pure estradiol. And people who were treating with estradiol knew what a milligram of estradiol was strength-wise. They knew what 2 milligrams of estradiol was. They knew what a half a milligram of estradiol was. That was the reference. That was the gold standard for years and years and years. And yet, the ovary didn't just put out estradiol.
Right.
The ovary put out 2 other hormonally active estrogens, at least. One of them was estrol, and the other one's called estrone. In fact, there's over twice as much estrone as there is estradiol. And there's about 1.3 times as much estriol as there is the sum of estrone and estradiol. In other words, the most prevalent estrogen is estriol. And I invite you to read Happy Healthy Hormones because I go into depth about that. So to make a long story short, doctors who I think care most about this wanted to copy nature as suggested by beloved Dr. Jonathan Wright. Let's all shout out and say a prayer for Dr. Jonathan Wright. It matters right now.
Okay.
I'm going to pause for a moment that we all consider this brilliant physician who's devoted his life. I want to say a prayer for him. And Dr. Wright came up with this idea in the early 1980s to copy nature. Why should we be giving women just estradiol when that's not what the ovary does? It produces more estriol than it does the sum of estrone and estradiol. Why just give estradiol? Estradiol is the most potent estrogen. And so he developed a formulation that eventually resulted in Biest. And what Biest is it's a combination of estriol plus estradiol. And there's about 4 times as much estriol in there as there is estradiol. In fact, a common percentage ratio is 80% estriol, 20% estradiol. Very common. That in most instances are going to replicate on 24-hour urine a pattern that's going to copy nature. It's going to be what young women produce. And there's very special reasons for this. We see that leads to diminished risk when you do this combination. And that's a whole other story. And I go into that story somewhat in the book and give you references if you want to track it further. Well, how do you know what the strength of Biest is if you've got 2 formulas in there and one of them is 4 times as prevalent as the estradiol, but 1/8 as strong?
Right.
So our team invented a way to look at that, to compare it by doing some math. So in a Biest formulation, we take the estradiol at face value, we give it the potency of 1, and we deal with the milligrams of estriol in there, and we divide it by 8 to sort of convert it to the potency of estradiol. So I'll give you an example. Estradiol, here's a prescription of Biest that's 2.5 milligrams per milliliter. I'm going to race through this. You can go through it in the book if you'd like the details. Well, if 80% of it is estriol, then 2 milligrams of the estrogens in there, 80% of 2.5 is actually estriol. And if 20% of it is estradiol, then 20% of 2.5 is, and I hope I got this right, is 5 milligrams of it is estradiol. Do I have this right? No, I don't. 0.5 milligram of it, 20%. So 2 milligrams of the 2.5 is estriol. 0.5 milligrams is estradiol. Well, we assign the estradiol the 0.5 milligrams of estradiol that's in a milliliter a potency of 1. So that 0.5 milligrams of estradiol is equivalent to 0.5 milligrams of estradiol in strength.
Got it. Okay.
And physicians who've been working with estradiol over the course of their career is going to understand that. But we translate that 2 milligrams per milliliter of estriol, we divide it by 8 because it's only 1/8 is potency. And that'll make us able to compare it to the strength of estradiol. So that would equal 0.8, an eighth of 2 is, oh, help me there.
You're the one who won that Berkeley Prize, not me.
It's, oh my goodness, I'm getting a mental dropout there. But 20%, 1/8 of 2 milligrams is like, I'm going to do the math here, and
Don't look
excuse
at me,
me,
Dick. Not gonna happen.
it's 0.25 milligrams. So
Marita got it.
the strength of bias, 2.5 milligrams per milliliter, 1 milliliter, is equal to 0.25, the potency of the estriol, plus 0.5, the potency of the estradiol, and we call that 0.75 milligrams of estradiol equivalent. In other words, 1 milliliter of that formulation is equivalent to, in strength, to 0.75 milligrams of estradiol. And physicians familiar with the strength of estradiol will understand that. Well, that's a lot to take in there, but that's what milligrams of estradiol equivalent is, and it's hard stop once again. So I am going to sign off. Carolyn and everybody else, nice to see you all, and we'll see you on Thursday.
We will indeed. Thank you for coming up. Thank you, dear Dr. David Rosensweet. We will see you on Thursday.